big welcome back, everyone, to another season of the Evidence-Based Hair Podcast. I'm Dr. Jeff Donovan, a dermatologist and hair loss specialist practicing in Canada. And I'm also the director of the Evidence-Based Hair Fellowship, a comprehensive training program designed to meet the needs of current and future leaders in the world of hair loss. Our current program has 126 incredible hair loss specialists from 34 different countries. And the podcast you're listening to right now is the official podcast of the Evidence-Based Hair Training Program. In this podcast, I review studies that are changing how we think about hair loss. I'll introduce them to you, help you make sense of them, and give you my thoughts on how a given study just might change how we diagnose or treat hair loss. And wherever you are in the world right now, please know that you're welcome. And if you wish to study hair loss at an advanced level, if you wish to study with an intensity that will equip you with the necessary clinical and problem-solving skills to help patients who experience all types of hair loss, both common and rare, early and advanced, simple and complex, then I invite you to apply to train in our Evidence-Based Hair Fellowship. It is the world's most comprehensive training program for physicians and allied health professionals. You can email us anytime, info@donovanhairacademy.com, or find us at donovanhairacademy.com. So today I'd like to review a very interesting study by Hassan and colleagues published in the Journal of the American Academy of Dermatology titled Dupilumab Therapy for Atopic Dermatitis is Associated with an Increased Risk of Cutaneous T-Cell Lymphoma, a retrospective cohort study. I use an increasing amount of Dupilumab for treating atopic dermatitis patients with alopecia areata. It's fascinating that Dupilumab can help some patients with alopecia areata. What's so strange about Dupilumab is it can also sometimes cause alopecia areata in some patients with atopic dermatitis, so it both treats and causes it. Let's take a look at this study and the background that leads up to it, and I'm sure you'll be as equally fascinated by it as I am. Dupilumab, Dupixent, is an IL-4, IL-13 antagonist, and it's an injectable treatment. Safety is pretty good. Many patients tolerate it very well. They don't need blood tests for the most part, and monitoring is quite easy. It's approved for a number of indications. It's approved for atopic dermatitis, and the age of approval has come way down. Now it's approved for 6 months and over. It's approved for certain types of asthma, prurigo nodularis, eosinophilic esophagitis, or EOE, and some types of chronic rhinosinusitis, and it's off-label for treating alopecia areata. In other words, it's not FDA approved for alopecia areata, but it can help some patients. Side effects are pretty reasonable. It can cause injection site reactions, as any injectable treatment can. It has a number of eye side effects, which are common, and we need to counsel patients about them, including itchy eyes, red eyes, dry eyes, and it can cause keratitis and conjunctivitis. It can cause eyelid itching and swelling, cold sores, and other side effects that weren't well described in the clinical trials but are now well understood in post-marketing studies, like rosacea-like lesions, weight gain, eosinophilia. It can cause alopecia areata, and we use it to treat alopecia areata. But then there's the lymphoma studies. Studies keep coming out showing a similar trend, and that is if you prescribe Dupilumab, you have an increased risk that your patient will be diagnosed with skin lymphoma, a specific one called cutaneous T-cell lymphoma. It's not a massively increased risk, but it's an increased risk. And as we'll see today, the challenge is, even though your patient has an increased risk of being diagnosed with cutaneous T-cell lymphoma, it by no means that the Dupilumab caused it. The big debate, as we'll see today, and the important message today, is we still don't really know if it fuels the development, unmasks the development. It was there, grumbling along, and dupilumab therapy prompted it to come out more. Or did it cause it? It's still a great debate. The data is challenging to decipher. On one hand, there are those pathologists and those specialists that believe that many of these lymphoma-like reactions are not true lymphomas, but are lymphoid reactions. They are lymphocytes with bizarre morphology that are doing bizarre things, but they don't meet the strict definition of a lymphoma, and they go away quickly when treatment is resolved. Study in JAMA Dermatology in November is worth reading, and I'll put it in the show notes, titled Dupilumab-Associated Lymphoid Reactions in Patients with Atopic Dermatitis. This study showed that dupilumab can cause reversible and benign lymphoid reactions that mimic CTCL or cutaneous T-cell lymphoma, but are not cutaneous T-cell lymphoma. That's one view. The other view is that no, dupilumab unmasks CTCL or lymphoma that was waiting there. These are true lymphomas, and they, in some cases, can kill patients. And the number of publications in the literature of patients that are dying is increasing. It's still very small. You can generally count them on one hand. But it's a reminder that this is a really important issue. That even if dupilumab doesn't cause CTCL, it in some cases can fuel it to come out more, and especially a particularly aggressive form of CTCL, which can be fatal in rare cases. Espinosa and colleagues published a nice report in JAD, the Journal of the American Academy of Dermatology, in 2020, titled Progression of Cutaneous T-cell Lymphoma after Dupilumab, Case Review of 7 Patients. Really important study back in 2020 when really this whole field was trying to figure out, what does this all mean? Espinosa described 4 patients that were given dupilumab for atopic dermatitis, 3 patients that were given dupilumab to treat itchy T-cell lymphoma. At that time, it was postulated that giving dupilumab to patients with lymphoma makes sense, because what seems to be happening in lymphoma is that levels of IL-13 are increased, and wouldn't it make sense to block IL-13? And what the Espinosa study in 2020 showed is that all these patients progressed. The 4 patients that were initially thought to have atopic dermatitis eventually received a diagnosis of CTCL, or cutaneous T-cell lymphoma, and the 3 patients with cutaneous lymphoma progressed to Sézary syndrome. And 2 patients died. Sézary syndrome is an advanced form of lymphoma involving widespread involvement in the body. Jfri published a nice study in May 2023 titled Diagnosis of Mycosis Fungoides or Sézary syndrome after dupilumab use, a systematic review. This was published in the JAD. Jfri reviewed 23 dupilumab-associated cases from 11 different sites. The mean age of patients was 58. Atopic dermatitis in these patients was mostly adult onset, 82% of cases, and childhood onset in 17% of cases. In 56% of cases, skin biopsies were done before starting dupilumab, and they weren't diagnostic of lymphoma. But in 5 patients, there were atypical features of atopic dermatitis: epidermotropism, follicular tropism, lichenoid inflammation. And Jfri showed that the mean time between starting dupilumab and developing biopsy-proven lymphoma was 7 months. 11 patients had advanced disease at the time of their diagnosis. And when they looked back at these cases, they found that there was 2 cases where it was clear that these patients had atopic dermatitis to begin with. They didn't have lymphoma. They were 2 cases with long-standing atopic dermatitis since childhood. Biopsies showed atopic dermatitis. But of the 19 patients with adult-onset atopic dermatitis, only 5 patients had clinical presentations that were really consistent with atopic dermatitis, and in many cases it really wasn't possible to exclude that the patients didn't have lymphoma before starting treatment. And so this is the big debate with this entire field of dupilumab-associated cutaneous T-cell lymphoma. Dupilumab is approved for treating atopic dermatitis. CTCL, or cutaneous T-cell lymphoma, can be a mimicker of atopic dermatitis. So are some patients in the world being given dupilumab for atopic dermatitis when really they have CTCL or lymphoma, and it's not realized that they have lymphoma? Are there patients out there that are misdiagnosed and they have lymphoma? It's thought to be atopic dermatitis. They're given dupilumab, and this fuels the progression of the lymphoma. We don't know. The theory is that all these are possibilities. That perhaps there are some mimickers that are misdiagnosed. Perhaps both situations may be sometimes present. But is it possible that dupilumab triggers de novo eruptions of CTCL? Well, let's take a look at Hassan, and then we'll conclude with some thoughts. This paper was published in JAD this month. So Hassan and colleagues used a large database to compare the incidence of CTCL in those that used dupilumab and those who never used dupilumab. It was an extensive database. Data was extracted from 60 healthcare organizations with 22,000 atopic dermatitis patients who were given dupilumab and 1 million atopic dermatitis patients that were not given dupilumab. And they showed that atopic dermatitis patients that used dupilumab had a 4-fold increased risk of CTCL. The risk was not increased for other cutaneous or lymphoid malignancies like leukemia, non-Hodgkin's lymphoma. And most of the cases of CTCL in this study were diagnosed more than 1 year after receiving dupilumab, which calls into question whether it is an unmasking of a misdiagnosed CTCL. If it's an unmasking of undiagnosed CTCL, you would expect the lymphomas to start showing up in month 3, 4, 5, 6, 7, 8, 9, 10, 11. But they don't. In this study, the delay was longer. Most patients having their diagnosis more than 1 year. So does dupilumab cause CTCL? Does it unmask CTCL? Well, you can either take a side. You can either realize that there's many unanswered questions in this field. But there are a few things that are clear. And I think as practitioners, we really would like things to be clear, and we're uncomfortable with uncertainty. We're uncomfortable with the need to have more data. We're uncomfortable with data that doesn't fit perfectly with other data. We're uncomfortable with waiting for long-term studies. But that's okay. We are human. But I think this data is certainly very interesting and certainly very relevant, and relevant to hair loss specialists who are thinking about giving dupilumab for alopecia areata. So what is clear? Well, it's pretty clear. If you give dupilumab for atopic dermatitis, or if you give dupilumab for atopic dermatitis and alopecia areata, then you're probably at increased risk for having a patient come back with a skin rash that causes people to worry. That is pretty much undebatable, that if you give dupilumab for atopic dermatitis, you have an increased risk of someone saying, I think I have a lymphoma. That doesn't mean the dupilumab caused the lymphoma, but you're at increased risk that a patient comes back and says, I have this rash, and that you biopsy it and it shows lymphoma. It's clear that if you have a skin rash before starting dupilumab, and it doesn't respond to treatment for the atopic dermatitis, that it needs to be biopsied to make sure you're not missing CTCL. That's clear. If you think a patient has atopic dermatitis, you give dupilumab, it doesn't respond, or it gets worse, or you get nodules, or you get tumors, then you have to biopsy it. And you have to biopsy it many times. Sometimes early CTCL is hard to diagnose in one biopsy. We don't yet have evidence that patients that use dupilumab for alopecia areata, who don't have atopy, develop skin lymphoma or lymphoid reactions. And certainly in all the patients with alopecia areata that are using dupilumab, we're not seeing case reports of CTCL. What is debatable is whether dupilumab actually causes lymphoma or a lymphoid-like reaction, or whether patients have this malignancy to begin with and dupilumab simply encourages it to come out. You can find papers supporting both sides. This particular study, Hassan and colleagues, is interesting because of the delay in diagnosis of CTCL. These patients are mostly developing their diagnosis a year later after receiving dupilumab. Other studies show the delay was short, suggesting, yes, it unmasks it. It adds something to precipitate the development of this lymphoma that was already brewing. This Hassan study calls that into question, saying, no, it took a year. Atopic dermatitis and lymphoma can certainly mimic each other. Cutaneous T-cell lymphoma can look exactly like atopic dermatitis. Now, there are certain differences, of course. Involvement of the flexural areas, may favor atopic dermatitis. But they can certainly mimic each other. And there are lots of fascinating cases in the literature of patients with CTCL that were first diagnosed as atopic dermatitis. But most of our studies still conclude with unsatisfying sentences like, this data raises question as to whether the affected patients were first misdiagnosed as having atopic dermatitis and the CTCL was unmasked by dupilumab, or whether CTCL is truly an adverse event from dupilumab treatment. That's how many of these papers are still wrapping up in 2024. Or comments like, lymphomas developing with dupilumab might be unrelated to the drug, but long-term follow-up data of large patient cohorts is necessary to rule out such possibility. Even the Hassan paper finishes with, in their discussion, it is unknown if dupilumab causes CTCL or unmasks CTCL. So I find this very interesting. I think that, when these studies first came out, the fear was that, oh wow, it seems that dupilumab may be precipitating or triggering or unmasking these CTCL. And then studies suggested that, no, we have to consider the possibility that these lymphomas were there to begin with, and dupilumab simply allowed them to grow quicker. And then there are these studies that suggest that many of these aren't really true lymphomas. They're lymphoid reactions. They're bizarre lymphocytes, but they're not really true lymphomas. They're benign lymphoid proliferations. So we've got all these views. I think that these conclusions to these papers are accurate, that as much as we would like to say, this is very straightforward, dupilumab unmasks a lymphoma that was already there, many world experts believe that we're still in the stage of accumulating information. For now, it's pretty clear that patients with atopic dermatitis who are considering dupilumab need to have skin biopsies if their cutaneous presentation of atopic dermatitis doesn't fit classic atopic dermatitis. If you have atopic dermatitis that starts in adulthood, never were affected in childhood, you might want to consider a biopsy. If you have a diagnosis of atopic dermatitis but you don't have a strong family history, you might want to consider whether or not a biopsy is helpful. If you have significant body area, it makes sense to do a biopsy to rule out erythrodermic forms of lymphoma. If you don't have involvement in the flexural area like classic atopic dermatitis, you might benefit from a biopsy. If you have atypical features like nodules or poikiloderma, then you could benefit from a biopsy. And if you start Dupilumab and you have new rashes or worsening of existing rashes, you have to have a low threshold for doing biopsies, and that's biopsies plural. Cutaneous T-cell lymphoma can be tricky to diagnose, and sometimes you need many diagnoses, many biopsies. But that's where we'll conclude today. I want to thank you so much for joining me for this first episode of this season of the Evidence-Based Hair Podcast. We reviewed this fascinating subject area of Dupilumab-associated CTCL diagnoses. Does it cause? Does it unmask? What is the current data teaching us and what further studies are needed? Very fascinating area, but it reminds us that we really have to have a low threshold for biopsying before Dupilumab is started and a low threshold for following patients and rebiopsying if unusual reactions happen, unusual rashes. Next week, we're back talking about drug-induced alopecia areata, a fascinating subject area in and of itself, that certain drugs, especially some of these new monoclonal antibodies that we use for a number of different human conditions, can trigger alopecia areata in some cases, and we'll talk about some interesting studies next week. I welcome you back next week for another episode of the Evidence-Based Hair Podcast. In the meantime, take care. Bye, everybody.